is prevalent in a lot of men with bladder cancer. I want to see, did my slideshow, are you still seeing my slides?
Yes.
Okay, good. So bladder cancer, is more prevalent, more common in men than it is for women. And you'll see it here in the slide here in the incidence case. Now, majority of bladder cancer will be diagnosed as in situ. So these are the CIS or localized, confined. And only a few will have metastatic or distant sites of metastases upon presentation, to the provider. And the way we look and assess, patients with bladder cancer, we always want to know what is the stage, is it low grade, high grade, what is the depth of involvement? So this is a quick snapshot. And if the tumor involves the muscle, as we see it here, less than half, more than half of the muscle, then that's a T2. Okay, or stage 2. So we divide it accordingly to T2A, or T2B. Now, the moment it involves the fatty area of the bladder, then that's T3. And T4 would be adjacent structures that the tumor has kind of gone onto. So muscle invasive bladder cancer is what we will be focusing on. Now, why is this an important, area of concentration? And that is because muscle invasive bladder cancer can be and is an aggressive disease. So it makes up about only a quarter of a lot of the patients who present with bladder cancer, but recurrences occur frequently, especially as the stage goes up, T2, T3, T4, and especially for node positive disease, as you see here. And the treatment for muscle invasive bladder cancer, so what do the guidelines say? AUA actually represents the American Urologic Association. So you'll see here the standard of care is giving neoadjuvant and adjuvant chemotherapy. So neoadjuvant means giving the chemo before one undergoes primary definitive cystectomy. So you'll see here, for those who are eligible for radical cystectomy, then we give chemotherapy. Now, radical cystectomy involves removal of the bladder, bilateral pelvic adenectomy, so meaning removal of the lymph nodes. And these are for patients who are surgically eligible. And that's why this remains the standard of care, for muscle invasive bladder cancer. And, these are the different diversions, which Kim will kind of go through in a little bit more detail later on in terms of management. But just as a general view, it could be a conduit, so removal of the bladder. And then there is an intestinal area that serves as the new, bladder. And there's a stoma that will be connected outside of the body. Or it could be a pouch. This is a continent diversion. So one must catheterize, here. Or it's a neobladder, which is kind of mimics the most physiologic, if you will, because it is connected to the urethra as well as distal ends of the ureter. Okay. Now, what to do after cystectomy? So let's say someone has undergone neoadjuvant chemotherapy, then cystectomy, and then there's still residual disease, either T2 disease or above, or node positive disease, meaning upon final pathology, we still see, residual cancer in the specimen. So there has been 3 major randomized trials, 2 of them have reported, one just recently closed, and they involve 3 different immunotherapy drugs. So if you were in the talk last week, Dr. Allen gave out a nice overview of the role of immunotherapy in non-muscle invasive bladder cancer. So these are all immunotherapy drugs here. So of recent, in fact, the FDA just approved a drug called nivolumab for adjuvant therapy for patients with muscle invasive bladder cancer who've undergone cystectomy. So this is, and I just included that for your reference. So this was just approved by the FDA around August of a few months ago. Okay. Now, what about what is said about muscle invasive bladder cancer as far as bladder preservation goes? So again, same statement, by the AUA. So a lot of patient selection has to go in terms of bladder preservation approaches. So these are for patients with newly diagnosed non-metastatic muscle invasive bladder cancer who desire to retain their bladder, or for whom there are significant comorbidities, for whom radical cystectomy is really not an option, okay? And also for those who prefer or for whom bladder preserving therapy is clinically appropriate. So there's a lot of wording here. So whenever we choose bladder preservation approach, we also have to keep in mind that maximal debulking resection, so TURBT, if resection of the bladder tumor, is an important part of this bladder preservation approach. And so this is an important or key part of the language that we tell patients when they are choosing bladder preservation. And what does the EAU, so this is the European, American, European Association of Urology counterpart of the AUA. So notice that their language is a little bit more as an alternative. So this is not a standard option, but they so choose this for patients who have no great alternatives, especially for surgery, and if they're not great fit for the chemotherapy. Okay. Now, why is there such a challenge with neoadjuvant chemo followed by surgery? So we see often enough that real world adherence is actually poor in terms of, surgery. And many, unfortunately, are not great candidates, So if the surgeon themselves are saying that, you know what, I'm a little bit concerned about you undergoing surgery, then oftentimes surgery may not be a great option. And this is also partly the reason why there is actually a high rate of mortality. 30-day, 90-day mortality is easily, close to 4.2%. And this is a reality that we face every day in clinic. Many patients are not considered cisplatin eligible. So cisplatin is part of the cocktail of chemotherapy drugs that we give for patients who undergo chemotherapy as part of their neoadjuvant chemotherapy followed by surgery. And cisplatin can only be given if you have good kidney function, if you have good cardiac status, meaning you are, kind of at your optimal best in terms of your performance status, no hearing problems, no neuropathy. Neuropathy is a big one because neuropathy is nerve damage. And a lot of patients who get cisplatin, unfortunately, can end up getting neuropathy. So up to half of patients who are actually considered cisplatin eligible may also refuse chemotherapy altogether. So this is a problem. And if we cannot deliver good chemotherapy prior to surgery, it may also compromise the efficacy or the treatment option in general. Okay. Now, moving on to bladder preservation strategies, as I mentioned earlier, a key principle is it's not like bladder preservation requires no surgery, period. Because remember, maximal TURBT is an essential part of the success of a bladder preservation strategy. So that means we're going to try and go in and remove as much tumor as we can that we visibly see. And that will make the radiation much more effective. Now, we utilize a lot of times concomitant chemotherapy, and I'll show you why in a little bit, and the chemotherapy portion can be anywhere and I'm just throwing out these names of these chemotherapy drugs. So 5-FU mitomycin, 5-FU gemcitabine, taxanes. Notice that we don't use typically, cisplatin in those who are not eligible for cisplatin. So we use alternative drugs. Now, there's a lot of innovations in clinical trials now with bladder preservation strategies. So we oftentimes ask the question, well, can we omit chemotherapy? Can we use other drugs like immunotherapy? And we capitalize on the fact that when we do radiation, we oftentimes emit a lot of neoantigen response that hopefully will make immunotherapy kind of work, so they kind of synergize, with each other. Okay, so this is a typical schema, and there are different paths of bladder preservation strategies here. So notice that maximum TURBT is kind of one of the hallmarks of that therapy. And then what happens afterwards highly depends. Some people undergo induction chemoradiation, meaning they go through both chemotherapy and radiation at the same time. And this is also essential. After each induction or full dose of chemoradiation, we would always have to evaluate, well, what do we see? What is the response to this chemoradiation? So that means, we need to go back in, look at the bladder and see what we find. Is there residual cancer or not? Because if there is, a lot of the treatment paradigm for bladder preservation strategies is we probably need to go in and do a cystectomy. Now, this is where the difference is between clinical trials and what happens in practice. So majority of patients in practice, when they go through bladder preservation strategies, I often tell patients that sometimes it is a one-way street. It's not like we can say, oh, if this fails, you can go back in and take the bladder out later on. Because if they went through bladder preservation in the first place because they were not a surgical candidate, then it's not likely a possibility that they're going to have their bladders removed in the future if there is indeed residual cancer that is seen. Okay, but I just want to point out that this is a lot of times how these bladder preservation trials were designed. Okay, now, why is it that we give both chemo and radiation? Because early on in a lot of the trials, we were seeing a lot of times that if we do radiation alone, it's not as good as giving chemo with radiation. So these are the typical plots that we see. Disease-free survival is how long one lives without disease. 5-year overall survival is how long one lives, by virtue of getting the treatment. So in all the curves, we will see that chemoradiation is almost always better than radiation alone. And that's why these are the typical combo, if you will, with chemotherapy. These are the drugs, that we typically use, and it comes in different sort of flavors, if you will. Okay. Now, these are the sort of next step strategies and clinical questions that we ask in the clinic. So number one is, can we forego cystectomy altogether and just use systemic therapy? And I'll show you a few trials that actually aim to try and do that. And what radiosensitizing agents, meaning combo agents, systemic therapy agents, are better perhaps than chemo. So these are the alternatives to chemotherapy. And I'm gonna show you a little bit of trials that are looking at that. So one of the trials that try to answer the question, can we get rid, quote unquote, of cystectomy? So this is the retained bladder. So my one caveat in a lot of the studies I'm going to be showing you, a lot of them are phase 2 trials. So that means, it's not yet being compared to the gold standard, if you will. So a lot of the phase 2 trials is trying to find if this technique, if this treatment is going to work So a lot of them have a single arm, meaning they have a clinical question and they're enrolling patients, small number of patients, to try and answer that question, but they're not comparing it to a current gold standard. Okay, so one of them is this retain. So what they did was they wanted to enroll, patients who had T2 and T3 disease, no metastatic disease. They're well performing, meaning they have a good performance status, urothelial predominant, and they're really asking the question, how good is this treatment that we won't see metastases? So metastases is spread of the cancer in 2 years, okay? So what they did was everybody got subjected to TUR, so resection of the bladder tumor. Their tumors were sequenced. So that means they were subjected to looking at the genomic analysis or sequencing of these tumors. So why these, gene mutations? Because there were earlier studies that indicated, that showed that if your tumor possessed any one of these, gene mutations, your response to chemotherapy may be exquisitely good. Okay, so exquisite sensitivity to response to chemotherapy may give rise to actually T0 disease. So that means if you undergo cystectomy, they may not even find cancer in that specimen. So this is the hypothesis of this trial. So if we have patients who we predict may do very well on chemo, might we observe them and not subject them to cystectomy? So this is really the basic premise, of this trial. So they go through chemotherapy as they would normally. So they use like the 4 drugs, accelerated MVAC, and then they go through another TUR to look at the bladder. And if they had no residual tumor, their mutation was positive, then they can go on to surveillance alone, no cystectomy. Obviously, if they have tumor, then they go down the path of the usual standard of care. They go through cystectomy. So what did they find? So 71 patients were enrolled. The cutoff was, T2 disease, 79% of them, 21% had T3. They went through the chemotherapy. Majority of them did and was able to go through 3 cycles of this accelerated MVAC. And this is what they found. So 33 patients, so a little less than half of the patient had mutation positive. A lot of them actually achieved T0, meaning there was no cancer when they looked in the bladder. So they began active surveillance. Unfortunately, a couple of them did sustain metastatic urothelial cancer. Now, contrast that to the patients who are mutation negative, 26% of them recurred. 9 had metastatic disease. There were a little bit more, patients who succumbed to the disease. So in conclusion, these are the author's conclusion. They continue to follow up a lot of these patients. It looks like the 2-year metastases-free survival is actually pretty good. Over 80% of them had no metastatic disease. A lot of them continues on active surveillance without, metastatic disease, and their bladder is intact. Unfortunately, 65% of them who had undergone active surveillance did have some kind of recurrence, typically non-muscle invasive disease. So they have cancer that came back, but it's not the same degree of muscle invasive disease that they had. There are a couple of trials that are still ongoing, and I'm going to show one of them. Now their final conclusion is risk-adapted bladder preservation is not the standard of care, but I wanted to merely show you that these studies are ongoing. So what are those other studies? So retain 2, the only difference is, you'll notice this, is the combo regimen for the chemo is different. It's not accelerated MVAC, but it's GemCis, but they added on nivolumab. So the Hoosier Oncology Group did an exact similar study like this, and they have actually some results. And what they found was 76 patients of them who got this regimen, 64 patients underwent clinical restaging. And those were like really good numbers, about close to half of them had some kind of response, and in fact, complete response. So meaning this is a viable option. Again, not standard of care yet until we get more information and more data. So this is a bigger study, it's an alliance trial, phase 2, and they're using a combination of gemcitabine and cisplatin, no immunotherapy drug, but it's the same concept. So they're taking patients with this, DNA repair gene mutations that would predict for response, to chemotherapy, such that perhaps we can spare the bladder. So very similar concept. Okay. Now, the use of immunotherapy is not without basis. So there were a couple of trials. They were like phase 2 trials, small trials that looked at the utility of pembrolizumab, which is an immunotherapy drug, or atezolizumab. And what they found was the pathologic complete response, meaning without chemotherapy, just immunotherapy alone, they did get good responses, 25 to 40%. Okay. Now, these patients did go on to get their bladders removed. And therefore, a lot of the current trials in this space right now, you can see a smattering of combination, pembrolizumab, gemcitabine, pembrolizumab, cisplatin, and there are some too that had no, chemotherapy drug altogether. So this is durvalumab, another immunotherapy drug with radiation. Okay, so this is one such trial. So this is a completely chemotherapy-free trial, that uses a combination cocktail of immunotherapy drugs with radiation. So what were they trying to prove and achieve? So they're trying to see if the patients can get really good response, complete response, and therefore spare, the bladder from being removed, so there was no cystectomy here, other than if the patients did not achieve a CR or they relapse, they then went on to get salvage cystectomy. So these are the eligibility for this trial. So the patients did have to have muscle invasion disease, and a lot of these are adequate, marrow function. So how many patients did they enroll? So they screened 47. They ended up enrolling 32 patients, okay? And these were at 6 centers, and they followed them up for about a year. These are the standard characteristics of these patients. Majority of them had T2 disease, so 87% of them. There were a few, 9% with T3 and 3% with T4, okay? And what they found was about 81%, so that's a really good number, had some kind of complete response. So complete response was defined as either no disease, T0, so that was achieved in 78% of patients, or T1 disease or less. So remember, these are the superficial, so 3% of them. Now, 6% had no response at all. If they started out with muscle invasive disease, they still had muscle invasive disease, okay? And these are, what they saw in terms of their long-term follow-up, the bladder intact, disease-free survival was about 73%. So that means 73% at the end of the year still had their bladder intact. And, there were some local failures, about 14%, and there were 12% of the patients who had developed distant metastases, okay? And what about the toxicity? So a lot of the toxicities you will think of as similar to radiation. So 41% of them had some kind of diarrhea. The grade 3 or 4 means the severity. So the higher the grade, the more severe, so 12% of them did have severe diarrhea. Urinary problems, typically frequency, dysuria, meaning difficulty with the urine, about 37% of them. And a lot of these, other side effects and toxicities usually refer to immunotherapy. So in immunotherapy, we see a lot of thyroid problems, sometimes, skin rash, or itching. Acute kidney injury or hepatitis, a lot of them can be autoimmune. They happen rarely, about 6% or less. And about 22% of them had to discontinue their treatment because of toxicity and other issues. Okay, so the authors concluded that this, modality of treatment, combination immunotherapy with radiation, is feasible and safe. But notice that they were a small number, right? 32 patients. So again, probably and still not yet standard of care, but I definitely just wanted to show you that a lot of such trials are currently ongoing. So at Inova, we will be opening up soon, a trial that is Keynote 992. So this is not also without chemotherapy, because you'll notice here that yes, we will be doing radiation chemotherapy, but an arm would have pembrolizumab. This is an immunotherapy drug with it. And the goal is really to try and see if we can improve the bladder intact, meaning patients can, save the bladder, and a lot of the secondary endpoints is how long they live, overall survival, and other endpoints like metastases, free survival. Okay, so in summary, chemoradiation as a bladder preservation strategy to control bladder cancer is definitely a viable option, for treatment, especially for those who are not eligible for that, cisplatin-based chemotherapy, as well as surgery, or those who simply choose it. There are a lot of patients who feel strongly that I don't want to lose my bladder, I want to keep it. I want to go through this chemo radiation bladder preservation option. So optimal regimens remain to be this, what I showed you in the earlier slides, chemotherapy and radiation. That still is kind of the standard of care. However, there are increasing number of clinical trials, and the ones I showed you is just a tip of the iceberg. There's so much more trials that are currently ongoing now, and in a lot of different combinations, no chemotherapy whatsoever, or just immunotherapy alone, with concomitant radiation. So there's a lot of ongoing exciting trials, right now, that is going on. So I think with that, I will thank you, for your attention, and I'll open it up, Stephanie, I think for, maybe a few questions, right?
Yes, if there are any questions, please drop your questions in the chat box at the bottom. So that was a great presentation. So I think it's really encouraging to see that there are a lot of different clinical trials that are out there. And, for many patients, clinical trials, they say, well, my doctor said they can't do anything else, so I have to go on a clinical trial. What is your thought on that, as far as, are clinical trials a viable treatment option?
Absolutely, and in fact, I often encourage, my patients too, if there was a clinical trial ongoing, and it's a good fit, right? Because understanding too that not all clinical trials are also meant for everybody, or all patients are a good fit for all clinical trials. So if it was a circumstance where, that's the right trial for me and it works, for all the eligibility, right? Because I always tell patients too, sometimes the challenge for clinical trials is, you know, your time may not be your own, you know, because there's a lot of, you know, I hate to say it, you know, but there are mandates, you know, within the trial, you know, you have to be at the doctor's office within how many days, you know, from the time of your scan and from the time of your surgery, you know, but this is really one way to get the field moving forward, you know. So had it not been for the patients who enrolled in those trials, the seminal trials that got us our standard of care, then we would not have known, you know, what the right thing to do is for the vast majority of our patients. So yes, the answer is we definitely would encourage clinical trial participation if there was one that was applicable, you know, to your particular case.
Mhm. So we are going to hear from patients with different types of urinary diversions and also who have gone through bladder preservation. So I think that this is great. I don't see any questions coming in. So if there are questions that you have for Dr. Aragon Ching about any of the things that she mentioned in her presentation, drop them in the chat box and we'll get to them at the end of the program. So Kim, I'd love for you to turn on your camera and then get ready to talk about the various issues with urostomies. And you can share your screen.
Thank you. Let me just get this up. Can you see that?
We can, it looks great.
So thank you for having me. My name's Kim Winter. I am a certified wound ostomy continence nurse. I work at Fair Oaks Hospital. Part of my role in my job at Fair Oaks is we run a outpatient ostomy clinic. So I do have a good bit of experience and get to spend a lot of time working with urostomates as well as fecal diversion ostomies. So I'm excited to present and thank you for letting me be here. So we'll talk about a little bit about stoma care. If you are to have, you know, go through with a either ileal conduit procedure. So the stoma is basically a diversion. It is a mucosal membrane that they kind of turn your bowel on the inside out and the stoma sits on your skin. So you do want to just cleanse the stoma with water and a washcloth. You wouldn't want to use any kind of moisturizers, baby wipes, peri wipes, anything like that. You really just want to stick with just water. You want to dry the skin very well before applying your pouch. The pouches don't really stick well if you have wet skin. Like we talked about, no baby wipes, towelettes, nothing like that. All of those things, they tend to have moisturizing agents in them, which really do interfere with the adherence of the pouch, which if your pouch isn't sticking well, you're going to leak urine and have some issues. So we recommend no powders or creams to the skin around your stoma unless it's been talked with by your ostomy nurse. Because the stoma is made of mucosal membrane, that when you rub it, it might bleed a little bit. A little bit of bleeding is fine. Typically, it just stops on its own and goes away. If you do have bleeding from your stoma that is not stopping and seems to be a little more than a few tablespoons, you do really need to get in contact with your doctor. And then the stoma has no nerve endings, so you shouldn't really experience any pain when you change your pouch. So more stoma care, you would want to assess the stoma and the surrounding skin. A healthy stoma is a variation of a red-pink color. Sometimes we describe it as beefy red, and then it's also moist. If your stoma is very dark or very pale, there are some things that can indicate, so you would want to talk to your stoma nurse about that or your physician. The surrounding skin or your peristomal skin should look just like the skin everywhere else on your abdomen. It should be the same color. If it's not, then there might be something going on. You might not have the best pouch. You might be leaking urine. You might be cutting your pouch too big, those types of things. So you really do want it to look just like the skin everywhere else. And like we talked about, a small amount of bleeding is when you're cleaning is normal. If you're wearing something, your seatbelt rubs up against your stoma, it's normal to have just a little bit of blood. After surgery, when they first make your stoma, there's a little bit of trauma. So it might be a little edematous or swollen. So your stoma will shrink in size in the first 4 to 6 weeks post-op. We typically say a good 4 to 6 weeks. However, sometimes in the clinic, I tell my patients, if you've changed your pouch 2 or 3 times and your stoma hasn't changed, you're probably set with that size. So types of pouches and management. Again, this is for an ileal conduit. There are one-piece pouches and two-piece pouches. The one-piece pouch is basically everything's integrated in one. The two-piece pouch is kind of like Tupperware. There's a lid and then the pouch. So the wafer would stick to you and would stay on your skin, and then you would change your pouch as necessary. The two-piece pouches are really for patients that have dexterity issues or visual impairment, where they need a little bit more visualization when they're putting the wafer on, and it's hard for them to do it with the one piece with the pouch integrated. But that's something that you can talk to your ostomy nurse about in the not immediate post-op period, but a few months after surgery to kind of identify the best pouch for you. There are some daytime management options with a leg bag. There's a picture below. And then nighttime management, you can connect your pouch to a bedside drainage system. These are just two pictures. One is a pouch, like a bedside bag, and then the other is actually a jug that sits on the floor next to your bag, next to your bed. You would want to clean those two systems, not your pouch, but the daytime management, the leg bag, and then the nighttime bag. You do want to clean those. So you can clean them with either white vinegar or a bleach solution. And I put the recipe there. The vinegar, it's 1 part white vinegar to 3 parts water. And then bleach, it's 1 part bleach to 10 parts water. So some basic self-care. It is very important. Your hydration is super important when you have a ileal conduit. So you want to continue to basically flush your kidneys. If not, you're going to be at risk for getting a kidney infection. So we recommend 2 liters of water per day. The goal is, a light yellow color of urine to kind of colorless. If you have a UTI, you might have very vague or mild symptoms. So it's something that you need to be attentive to and, seek care early on if you think you have something going on. There's also recommendations for vitamin C supplement. And then when you have a pouch with an ileal conduit, the goal is to change your pouch every 3 to 5 days, or if it's leaking, obviously. However, I always tell my patients, there's no hard, fast rule. 5 days is not better than 3 days. What you really want is to have trust in your system. And so if that means you change your pouch reliably every 3 days and it never leaks, that's better than trying to get to the 4th day or the 5th day and constantly dealing with leaks that impact your quality of life and cause frustration. So you really need to take the time to learn about your pouch and kind of build this trusting relationship with it before you get into like a set routine. And then you always want to wash your hands before and after, just because you really want to be protect yourself against a urinary tract infection. Diet, there's really no changes to your diet. You can eat a normal diet. There are some, definitely odor producing foods. Asparagus is one that causes significant odor to your urine. And then to decrease odor, you can have things like cranberry juice, yogurt, buttermilk. But there's no, for a ileal conduit urostomy, there is no diet changes. And then adjusting to urostomy. So this is kind of after you've had the surgery and, telling others, you really need to share what you're comfortable with. People, you will feel when you're walking around, going out to the grocery store, that you'll feel like everyone looks at you and knows that you have a urostomy. They really don't. So people will only know if you tell them. So if you don't want people to know, you don't have to tell them. However, I do encourage patients to kind of be willing to share, because in the United States, we really don't normalize stomas. And, everyone urinates, everyone poops, and we have such a prevalence of cancer that we really need to normalize these things so that people get care earlier rather than later and have bad outcomes. So I do always encourage people, after you've adjusted, to kind of become an ambassador for living with a stoma and having a great quality of life. There are some significant psychosocial aspects. So it is very common to feel discouraged, isolated, and alone. When you come to clinic, we always recommend, talking to a trusted friend, a therapist, a nurse, someone else that can help you work through your feelings. Your social life doesn't have to suffer because you have a urostomy. Again, people will really not know that you have the urostomy unless you tell them. So you can still go out, you can resume your, normal daily activities, you can, meet people for lunch, you can go shopping, things like that. You don't really have to change. Sexuality is very important. Sexual relationships and intimacy are important and fulfilling aspects of everyone's life and should continue after your ostomy surgery. Communication is very important for having a healthy sexual relationship after an ostomy. So it is important, to have your partner be involved, have them come to the doctors with you, have them be involved if you're comfortable with it, with your pouch changes, your management, coming to the clinic, those types of things. Communication is very important. So hospitalization after your initial surgery, if you were to be hospitalized for something else and you are an established urostomate, you would want to bring your own supplies. The hospital will have supplies, but if you're using a unique pouch, most hospitals don't have a bunch of different urostomy appliances available in general floor stock. You also might find that you are the expert on urostomies and find yourself educating your nurses and the techs. Before I was an ostomy, certified nurse, when I went through school, there's not much education that, nursing school gives about patients with an ostomy. You learn most of it on the job. And if you don't work in a setting where you have those patients, you don't learn much of it. So you may find that you're your expert, which is good. You need to be your own advocate. And again, always be an ambassador. So just take that time, work with the nurses, and make sure that they are doing what you need them to do because you are your own expert. A little tip about urine specimens, if you were to go to the hospital, you want to make sure that a new urine specimen is taken either directly from your stoma or that you take off your pouch, clean your stoma, put a new pouch on, and then take it directly from that clean pouch. You don't want to take a urine specimen that's from an old pouch that's a few days old with stagnant urine. Returning to work, as you recover, you will be able to resume your normal daily activities. It takes time. I always tell my patients, you've had major surgery, you've had time to, rest and recover. You have to be patient with yourself to get back to where you were. Being in the hospital and just being, in a bed and laid up really takes its toll on your overall body. So you just kind of have to give yourself that time to get back to what you were doing, but you should be able to. There are precautions that you need to take, for the forward part of your life for heavy lifting and high contact activities. Patients are at risk for developing a hernia around the stoma, and you do want to make sure that you protect yourself from that. So lifting and high contact activities are some things that we try and limit. Clothing, there's no real special clothing that you need after surgery. Again, it's just going to be trial and error that you find as you become to be the expert for your situation and your ostomy and your body, what your preference is. So you might need to make some minor adjustments for your comfort or preference. Tight fitting pants, if they interfere with the urine draining out, I imagine that wouldn't be comfortable, so I wouldn't think you'd want to wear that, but you would maybe not wear that if it's interfering with the urine draining into the pouch. There are lots of pouch accessories that you can find online through Etsy, lots of places. So if you wanted to use a pouch cover, you could certainly use something like that. There are also devices if you are, active in contact sports, maybe soccer, football, really heavy contact sports. There is a device that you can get, a stoma cap that's a hard plastic device that can go onto your pouch and cover your stoma. I would recommend you talking to your physician about that prior to just resuming your contact sports. But if they know that there's a device you're using to protect your stoma, they might be more likely to give you the green light to go ahead with that. Swimming, patients living with an ostomy can swim. The hot tub, if you're, that water is super hot, so you might not get as long of pouch wear time, but you can go in the hot tub. Waterproof tape at the barrier edge will help if you're swimming in the pool, a lake, an ocean, something, just kind of helps give your pouch that waterproofing. You may need to change your pouch more frequently in the summer months if you're swimming frequently. And then you do want to always empty your pouch before going in the water. And then bathing suit is based on your personal preference. Travel, you can travel however you would like with an ostomy. There's no specific way of travel that's excluded. But you do want to make sure that when you travel, you're fully prepared with supplies and materials. And then the UOAA, which is a great resource online for patients living with an ostomy, they have a ton of travel recommendations on there, and that website is just ostomy.org. That's actually the reference here. So ostomy.org, they're a wealth of information for you. I didn't really talk about continent reservoirs and living with, oh, I thought I logged out. I didn't really talk about continent reservoirs or an Indiana pouch, but I can certainly answer questions if you have questions related to that. So thank you.
Thank you so much, Kim. I actually dropped a couple of things. You were so thorough in what you were talking about. I dropped a couple of resources into the chat. For instance, we have a page that's dedicated to traveling with the urostomy, and there are tips that were generated by patients who have already had radical cystectomy. And we had another program that we had done. You talked about the psychosocial impact of a radical cystectomy. And we just recently did a phenomenal program with a physician who is up in New York, and he did a wonderful job talking specifically about that. So at the end of the program, you can go check out those two links if you want to go ahead and open them up. And we did actually have a couple of questions. The first question that came in, I keep getting different opinions on how long we should change our night bag. What's your opinion? And does the water vinegar mixture in the night bag really give any antibacterial results?
Yeah, absolutely. That's what we recommend to our patients. We actually use, from a wound perspective, we use a dilute vinegar solution frequently because of its antimicrobial benefits. So absolutely, that is how you should clean your pouch. It should be either with dilute vinegar or dilute bleach. I think how the differing opinions on how you should change I'm assuming that means, throw away your old set and get a completely new set. I believe insurance will cover 1 to 2 night bags per month for most insurance carriers. So I think that should be probably your goal, but also based on how much you're cleaning it, you might get a little bit more longevity from your nighttime drainage system if you're cleaning it more frequently, letting it air dry. Maybe you have 2, you clean 1, kind of swap them in and out. But absolutely, the dilute vinegar is great for the antimicrobial.
Okay, can you give that recipe again for making the
Yeah.
solution? Somebody asked what the strength of the vinegar would be. How many parts of vinegar to water or water to vinegar?
Yeah, I can type it in the chat too. It's 1 part white vinegar to 3 parts water. So if you usually, it's like if you did 1 tablespoon of white vinegar, then you would do 3 tablespoons, the equal, 3 parts water. We usually say 3 tablespoons of white vinegar to a quart of water. That's what we tell our patients. And then bleach, I'll write it too also when we're done our chatting.
And the recording of today's program is going to be available in the next couple of days. So you'll be able to go back and listen to it again if you would like to. And then there was another question about the urostomy impact on athletic activities. I think, Kim, you did a fabulous job. I had not known about the little hard cap that you can put on top. So then your bag is underneath that cap as well.
Yeah, it actually Velcro. So the little cap comes with 2 pieces of Velcro. So the 1 set of Velcro is on the cap, and then the other set of Velcro you actually attach to your pouch on the part that's right over your stoma. So you don't have to wear it all the time. You can, take it off, especially when you get a new pouch, you reseat it. But yeah, the stoma sits right under that. It's like a little dome.
Okay, great. So for something like weight training, though, you wouldn't necessarily need the cap unless you were going to accidentally drop your weights on your lap, which is not a good idea. Yeah. But in terms of support for that kind of activity.
So weight training is something that I always recommend patients talk to their physician about before doing, because you really do want to be careful with the type of weight training that you're doing. I always, hesitate when patients are doing CrossFit preoperatively. I'm like, CrossFit's really intense. There's a lot of intra-abdominal pressure that's going on, and that just increases your risk for hernia. So with weight training, if you want to wear a belt, there are things like stealth belt, which kind of keeps everything, right close to you. It's not really like a weight training belt. I think depending on where your stoma is, you probably would not be able to wear one of those leather weight belts. Running is fine. You might have to change your pouch more frequently if you're sweating, especially during summer months. Swimming is fine. Again, you just might need to change your pouch more frequently. Walking is one of the best exercises that you can do. I just hesitate with those weight training. Anything that's going to increase your intra-abdominal pressures where you're straining, that's really going to put you at risk for a hernia.
Okay. And it's running. A lot of people like to run. Is there any recommendation? Should they do anything to hold the bag in place when you're running?
No, so I mean, Stealth Belt makes a great product. You can use that. It kind of keeps everything right together. I would definitely empty your pouch before you go for a run. Yeah, there's really nothing. No, I mean, can kind of resume everything once you're kind of cleared to go back to your daily life and your comfort level. And it's something that again, you'll become an expert with over time. Trial and error, how things work for you. How does it feel to run? Do you, if you run first thing in the morning versus late in the afternoon after you've been drinking all day, those types of things that you'll kind of come to find out what works best for you.
Okay, great. This is really helpful. So Karen, do you want to turn your video on, or Jenna, are we ready to do the patient panel? I know you've been trying to get everybody in their seats in the Zoom room. I know we have Nancy here.
We've been trying, yes, quite unsuccessfully.
Well, Dr. Aragon Ching, if you want to turn your microphone back on, and Nancy, if you want to turn your camera on, while we're waiting to see if everybody else gets in, I'll let Karen and Jenna figure out how to get them into the Zoom room.
Right.
But we can definitely start with Nancy, who is a long
yes, we have a panel of one, and I'm so glad she's here. And she's coming to us from North Carolina.
Yeah. And I think we can just, start off, and if we find that we don't get, the, other panelists in, then, we'll open it up maybe also for the floor, for all the participants here today, so that we can make it an informal kind of discussion, open discussion, what your thoughts are, and, we can go from there. Okay. Well, let's get started. And again, can I call you Nancy? I usually Miss Lucy, but we're a little bit more informal here. So Nancy, thank you so much again for joining us, and I know your insights and experience is going to be very valuable, to all of our, participants here tonight. So my first question is, I just want to get like a brief overview, of course, your cancer diagnosis and how it kind of, came about, and, and we'll start from there, just a little brief history, of what your cancer diagnosis journey is, and the sort of diversion you opted for. So.
Okay, I'm glad to share. I have actually written notes, otherwise I can talk for a long time, and I won't do that. I first began seeing blood in my urine in 2006. I was at age 59. My primary care doctor was first concerned that I had uterine cancer because I had been through menopause and thought it might be related to that. So I went for a biopsy with my gynecologist. It was negative. I then went to a urologist to be checked. I had a CT scan prior to the appointment, and that CT scan showed that I had a tiny kidney stone in one ureter. Well, the urologist then very, I thought, kind of a snap decision, decided that the stone was causing the bleeding. And 6 months later, I was still having bleeding and seeing blood in my urine. And when I went in again, the next CT scan indicated that there was something that really needed to be looked at. And it said, and I will always remember on there, that it may have been there previously. So I was panicked, and I think the doctor, the urologist, may have been panicked also. At that point, I decided to get a second opinion. There was a papillary tumor present, and we made arrangements to do a TURBT, remove it, and then do some biopsies. I say some of this in background because women traditionally have trouble getting a diagnosis. And I think a lot of times it's because primary care doctors or other people are not expecting to find bladder cancer. And so they kind of, if they're not thinking it's going to be there, often they don't really look hard for it. I think that's changing a lot now, but I've heard this story way too many times from other women to know that that it was, my situation was different. So I did do TURBT, and for the next 2 years, I had BCG treatments and would go every 3 months for cystoscopy. And occasionally I would have biopsies taken in the surgical clinic at the urology office. That also was a time that BCG was not in short supply, and the protocols were different at that time. Finally, in December of 2009, my biopsy showed that I had carcinoma in situ. It was still non-muscle invasive, but everywhere that my urologist did biopsies, the random places were all CIS. The places that he looked at that had been little red places that we were kind of going in to look at were not a problem at all. So when I went in for the pathology report, and my urologist and I decided it was time to have a different talk and not be discussing BCG anymore. We discussed radical cystectomy, and he, what was going to be a 10-minute appointment became an hour appointment. And he graciously went over all 3 diversions with me, drew all these pictures, listed pros and cons. He said, don't make a decision today, come back next week. So that's what I did. And we talked about it all over again. I told them that at that point that I had decided to have an ileal conduit, and he assured me that I could make up my mind or change my mind if I needed or wanted to up until day of surgery. So we went ahead and set the date for February 15th of 2010, which was 6 weeks away. And then I was prepared for that. I can go ahead and tell you more about how I chose my diversion if you'd like to do that.
Absolutely.
Okay. Well, I chose an ileal conduit as my diversion after I spent some time reading about neobladders and Indiana pouches. And then I was fortunate enough to be able to talk with several people who were living with those diversions. At the time, neobladders were pretty iffy for women. I could end up with a lack of continence, or I could have been unable to void. The stitching and the healing were, it seemed from the people, the women I knew who had it, was pretty key. And I spoke with a woman who did have a neobladder, and she really regretted her decision. Now, that's not to say that all women regret having neobladders. It was, but for my experience, 11 years ago, that was one of the factors with it. I actually knew a woman who had an Indiana pouch, and so I was not only able to talk with her about her experience, but I was able to see she showed me her stoma, she showed me her little catheters and how she catheterized herself. And she was very frank in her explanation of how she had to empty the pouch on a regular schedule, night and day. Although she was satisfied with her Indiana pouch, I was not sure I really wanted that rigid scheduling night and day. And neobladder is the same thing. To train, to really get yourself there, there was going to have to be scheduling and planning around that. So both the neobladder and Indiana pouch had longer recovery time, and there were issues of leaking during that time that I was hearing about from people, particularly at night for Indiana pouch. And, the issue of getting on a schedule, and all of that was a pretty big negative for me. I was able to talk with two men, interestingly, in my hometown, and I've talked to the men in person. I talked with two women whom I was able to connect with through Beacon, and all of them had ileal conduits. All of them were satisfied with their diversion, and so I just decided that sounded like the most reasonable thing for me. At that point, I was 62 years old, but I was an active 62 and was still working. All right, so here's
Nancy. Actually, I'm, and I think that journey is amazing in the sense that, you really did a lot of homework. Like you talked to a lot of folks. You actively, sought out all these different opinions, because sometimes it's very hard, very difficult from the patient standpoint to say, oh, my doctor just said, boom, 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 these are X, Y, and Z, your options. And you're like, how do I choose, right?
right.
So, and maybe, this experience that you're sharing with us is very valuable, and what would you kind of tell, our sort of folks and anyone else who's going to be listening afterwards, understanding that, of course, there's going to be a good mix of a lot of our participants, maybe they have their own journeys that they've already chosen, right?
Right.
But for the people who are in that, particular spot of, I don't know which one to choose, I mean, what would you advise them?
Well, I would definitely advise, if you have other people to talk with in person, that's great, or through Beacon, because Beacon can put you in touch. So I've talked with 3 people this week who are facing surgery and are trying to decide on a diversion. And I think that's really important. Beacon's Survivor to Survivor, you just call them and get in touch. The other part of it too is to listen what other people have to say, but no, it really kind of comes down to your own personal lifestyle, what things are important to you. For quality of life after the surgery, what things do you want for after surgery? I based it on, I wanted a shorter surgery that had been done longer, that felt more certain to me. I wanted a shorter recovery time, and it seemed that would be in line. In fact, I was back at work in 6 weeks after my radical cystectomy. I wanted I wanted to be able to attach to a night pouch so that I could sleep at night. I did not want to be having to get up on a schedule. To get a good night's sleep was important. I was not concerned about body image and wearing a bag on my body. And see, that can be very different. If I had been a different age, a younger age, or if I had been single, or something like that, that might have been a different priority. But for me, that was not a concern. Um, this was kind of a concern that I don't hear people talk about a lot, but for me, it was important. I thought, if I have a stroke or some kind of impairment down the road, because I'm planning to be here down the road, if I have that, I might not be able to manage catheterizing myself. And I would be able to, someone would be able to change a bag for me if I could not manage it myself. Or if I were bedridden, I could have like a night pouch there. And so I felt like I would not be a burden to other people, and it would be easier to manage that. Now, some people might say, well, looking down the road, I want to live the way I'm living and worry about that later. But at 62, it was a concern for me. And I wanted the easiest kind of solution that I had. And then another thing was that, the urostomy bag doesn't have to be changed every day. So, if you can go 4 or 5 days, you shower in between, bathe in between, do whatever you want. It's not like a lot of people think you have to change a bag every single day. And that's not true. And the bottom line is, I had talked with people and met people who were living vibrant and lives and enjoying life. And they were doing pretty much what they had done before. And I just wanted to be like them. They looked healthy and they were having good quality of life. And that's what I wanted with that.
And Nancy, maybe if I can, if we go back memory lane, go down memory lane, right?
Yeah.
When your urologist kind of first told you, okay, we got to do this cystectomy, what was, your thoughts then? I mean, what was running in your mind? Did you ever think, wow, is that really what I need to do? Or how did you take it?
Yeah, actually, because I had bladder cancer diagnosed and did a couple of years, about 27 BCG treatments, and then had, all of that, I really had time to think about it. And I had an experience where another older gentleman who I knew, but not very well. And he's told me one day, he said, if you ever reach the point you have to have your bladder removed, he said, I'm going to tell you, don't be afraid. You can do this. And so I kind of put that little bit of encouragement, I call it in my hip pocket. And anytime I get a little nervous about things maybe not working out so well with BCG, I would pull that out and think to myself, it's okay. If I do radical cystectomy, I can do this. And I know people who have done it. And so the actual time when I went back and we said, we need to have a different conversation now. Instead of treatment, maybe we need to talk about cystectomy. I was not worried about it. The time I was really worried about the whole thing was in the very, very beginning of being diagnosed, when I went into the primary care's office because I thought I had a UTI and was showing some blood initially. And that was 2 years before all of this. But I went in and she said, well, we'll go ahead and we'll culture this, but I don't think you have a UTI. And I looked at her, and I'm really kind of embarrassed to say this, but I looked at her and I said, well, what else could it be? And she looked at me and she very gently said, well, it could be bladder cancer. And I thought, what? And I was just kind of panicked at that moment. But, I had time to kind of work into it. So I wasn't worried. Maybe it was foolish, but I wasn't worried about radical cystectomy at all. I just felt confidence in my doctor. I felt confidence in knowing people who had gone through it, and it was just not, they pulled out of it and recovered. So I wasn't blown away by that. but I was in the beginning blown away by bladder cancer in general.
Yeah, no, wow. Yeah, no, that's a very important insight, of course, because that's not always true for everybody, right? Like the
Right,
moment,
right.
and I know this too firsthand. I mean, nobody wants to ever hear, your bladder's gotta go, so and there's a lot of other implications to it, as you mentioned, like body
Mhm.
image, how is it going to affect your day-to-day, activities. And what would you say, Nancy, would be kind of like the biggest challenge, so it sounds like, you coped very well, but if, in the ideal world, what do you think? I mean, could have been done differently, or everything kind of went smoothly, knock on wood.
I think two things. After I had radical cystectomy, the first thing was when the hospital lined up home health care to come out. I think it was 3 times a week that we did it. The nurses who came were wonderful, and they were great at checking to make sure I had no infection and was healing and all of that. But they admitted to me they really didn't know much about ostomy care. And so after a couple of weeks, I was, when I was at home by myself for that, the kind of the first week when everybody stopped coming by and everything, I changed the bag, and then in a few hours I had some leaking. And I was kind of discouraged by it. So I changed the bag again, according to what they told me to do in the hospital. And a few hours later, the home healthcare nurse said she was coming by that afternoon. And I said, great, bring anybody who understands ostomies, because I really need some help. I'm going to be back at work in about 3 weeks, and this is going to be fixed, and I'm going to do it. So she came and she brought the person who was head of the home health care business company, and a new nurse that they were training in. So we all worked it out, and they helped me get my bags ordered and get all that straight. That was my first challenge. And then the challenge I live with now is, like Kim was saying, I have a peristomal hernia, and it developed gradually. And so, now I consider it significant. I wear a hernia belt, which provides support for it and everything. I do think I need to be careful, and I will always need to be careful to keep a fairly stable weight, with not gain a lot of weight or lose weight, so that I have wrinkles or expanding. So I think that's important. When I do that, I find I can manage it better. And I also sometimes find that I need to watch a little bit what I'm eating, and not add too much fiber to it. But in general, I eat whatever I want. But I would say lifelong challenge is going to be this hernia. And I have met with a surgeon just to meet with him to discuss it. He knows I'm not crazy about having abdominal surgery again. And a couple of the doctors that I know through Beacon, when I mentioned it, kind of said, no, I don't think you want to do that. And so I feel like I've kind of checked that out, and I know that it's okay. And so I will just manage the best I can with that.
Yeah, thank you, Nancy. And actually, if I may, I'm gonna, call out on Mr. Hoffman. Can you hear us? I know you were having a tough time joining via Zoom, but I think I see you on the number.
So I think Dr. Aragon Ching, I think he popped off again. So we're trying to get him back. We saw the number pop on, we saw the number pop off. So our goal is to
Is
get
Patrick
him back on.
Is Patrick here?
I
Yeah, I'm
don't
here.
think so, right?
Oh, yay, Patrick.
Hello.
Okay.
Can you hear me?
Hi.
Can you hear me?
Yes.
Yes, we
Okay,
can.
great.
Yeah.
Thank you.
So thank you. So Patrick, we were just starting, well, we have been, discussing with Nancy, her experience, she had a bladder cancer surgery, uh, over a decade now, right? And we were talking about the diversion. And I want to kind of maybe turn to you now, Patrick, to give us a little bit of brief overview about your cancer diagnosis, how you got to your decision about, your diversion. So maybe let me turn the floor over to you.
Sure. Yeah. So for those of you who don't know me, I have a neobladder. So in 2013, I was 45 at the time. I saw some blood in my urine. I went to a urologist, and the nurse there just kind of looked at me puzzled. She's like, "You're way too young to have bladder cancer." So she reckoned I probably injured my kidney somehow. They didn't do a urine test or a blood test or a cystoscopy or anything of the kind. She just kind of dismissed me. And so I was like, all right, that's fine. 2 years later, I was living and working in Toronto, and I saw blood in my urine again. It's the difference between their healthcare system and ours is that they were like, oh, that sounds serious. Let's do some tests. So they did a sonogram. First of all, they said, yeah, there's definitely something in there. A couple of days later, did a cystoscopy, and it confirmed the presence of tumors in the bladder. Some more tests confirmed I had stage 1, grade 3 with a lot of CIS. And so my urologist recommended initially a more conservative approach for about a year. There were a number of treatments. I had 3 TURBs, basically to scrape out the tumors. Three separate small surgeries, 6 installations of BCG, 3 installations of mitomycin C. None of these things worked. So after a year, so it's August of 2016 now, he recommended that we do a radical cystectomy and prostatectomy, and he said I was a good candidate to have a neobladder because of my young age and overall good health, and so that's what we did. And there wasn't even an issue. There wasn't even a question of, do you want to have a bag or a neobladder? He's like, you definitely want the neobladder, because pretty active, so the only I guess dispute or question was he wanted me to do a sperm bank thing because you lose the prostate, but I by that point I was already 47. I don't have kids, I don't want kids, so I was like, no, let's just forget about that. At any rate, so yeah, that was August of 2016. There was nerve sparing surgery with the prostatectomy and the now I have a neobladder. It was a 6-hour procedure. I was in the hospital for 12 days, 7 weeks of recovery at home. And yeah, it turned out to be a good decision from a perspective of we could have done conservative treatments. Maybe it would have worked, maybe it wouldn't. But I was told that if it goes to stage 2, if it becomes muscle invasive, then it's a coin flip. With how long you'd live. If you live past 5 years, it's like it's 50-50 at that point. Whereas if I did the radical cystectomy and all of that, the odds are much better, closer to 90%. So that sealed the deal. We tried for a year to keep the bladder, but it wasn't going to work. So I went ahead with the neobladder. And so if people were to ask me what's the pros and cons of doing a neobladder, and from what I understand, it's not very common. Most people have, the bag, especially if they're older or maybe not as active. But the pros are that if you are active, if you're young, it's good because there's no outward evidence of, ever having had anything wrong with you apart from some scars on your abdomen. So there's that, and it allows me to be continue to be really active. And I have full continence while I'm awake. You never know. I mean, 5 years on, you'd never know that there was any problem. I've kind of gotten used to this whole new way of doing things. The cons are that at night you have incontinence while you're sleeping. So my workaround is I have condom catheters attached to a hose, which goes over the side of the bed with a bag there. In the morning, I just, rinse it out. I replace the bag every month. No big deal. And I have to do intermittent catheters 4 times a day. And that took a while to get used to, because, shoving things up your urethra is no fun at all. But after a while, you kind of get used to it. And you realize you have to do it, because you just, and especially when you first get a neobladder, you don't recognize the signs. It's not like, when you still have a bladder, you have that familiar tingle. Oh, it's time to go to the bathroom. With a neobladder, you don't have that anymore. So you have to recognize what the signs are, and it takes a while. And at first I wasn't catheterizing as much, and it would leak, and it was a big problem. And I was like, oh man, this is terrible. But once I started doing the catheters 4 times a day, it's helpful, not only to fully void the neobladder, but also, this is really important, to get the mucus out, because the neobladder is made from your own small intestine. It's got mucus in it, and if you want to get all of that evil stuff out of there, then you have to catheterize. There's just no 2 ways about it. And so now that I've gotten used to, what to do while I'm sleeping, doing intermittent catheterization 4 times a day, it's a new reality, and it took me a while to learn, but it's been 5 years now. I'm cancer free, and I feel like it's the most minor of disabilities, and I'm just lucky to be alive and as active as I am. So that's my story.
Patrick, so you continue to self-catheterize now?
Absolutely, right? 4 times a day.
Yeah. And would you say, what if looking back, what would be your biggest challenge? I mean, would it be that self-catheterization or something else,
Initially it was, yeah. For the first year or so, I was reluctant to do it because it hurts, and it's unpleasant. And dealing with medical supplies, and it's like, it's like I lived through cancer, now I got to deal with this crap, so. But eventually you wake up to the reality that this is something you have to do. And so I forced myself to learn how to do it. And now I'm glad I do. It's no different than brushing my teeth or, whatever, doing any other function that you need to do on a daily basis. So, you brush your teeth 3 times a day, while I catheterize 3 or 4 times a day, no big deal. So, but so now, to answer your question, there's really nothing that is standing in the way of my living a normal life now.
Yeah, it sounds like too, at the time that you were offered the options, it sounds like really neobladder is the option for you, so it almost sounded like, the urologist also preemptively already guided you to the decision that because you are young, neobladder is probably the path, for you. Did you feel that way, or did you go ahead and like research on, oh, what about this, pouch, or what about this conduit?
Yeah, for me it was a no-brainer. I mean, being only 48 years old and single, and like, the choice to have a bag on my side, no offense to anybody who has that, I'm just saying, for me personally, the choice between that and not having that it's not a choice at all. I mean, I went with the choice that was recommended to me, and I was fortunate to be living in Toronto and have my urologist slash surgeon was the person who he had done more neobladders than anybody in the entire country of Canada. So I was really fortunate in that regard. And, he did a great job and, patched me up, and it took a while to kind of learn a new system. You've been doing one thing your whole way, your whole life for 48 years or whatever. And now you have a new way of doing things. So you have to learn it. And once you learn it, then you realize it's fine. It's fine now. At the time, is a huge bummer, but now he almost wasn't able to do it. Apparently, the taller you are, the harder it is to do a neobladder. And I don't know the technical reasons for that, but he struggled with it, to actually make it happen. But in the end, the procedure was successful, and I'm grateful for it.
Yeah. No, it sounds great. And actually, if I may, I see that Mr. Hoffman, are you on the phone line? right now? Can you hear us? Let's see.
Mr. Hoffman, can you unmute?
Because it's a
I
phone.
can't unmute him myself, but I did ask him to unmute. So hopefully,
Oh, I thought we would be able to unmute him.
we can't unmute him. He is muted from his phone. He has to unmute from his phone. I'm not sure how to get him to do that.
Let's see. Wonder if he
Yeah, star 6 is the answer. So on the phone, Bill, if you, yep.
There he is. I see him coming in there.
Mr.
Hi, Bill.
How are you doing, Dr. Argon?
How are you? Thank
I'm
you
good.
for
I
joining.
can't see you, but I can hear you.
That's okay. That's okay. So we're in the quote unquote Zoom room, Mr. Hoffman. So so maybe what we can do is, Mr. Hoffman, if you can, please, tell, the rest of the participants, everybody here, quote unquote, in the room, sort of how you got your journey in your diagnosis for the bladder cancer and the treatments, you went through and you chose.
I will do that.
Yes.
Okay, I'll start now.
Mm-hmm.
Back in 4th of July of last year, I was urinating blood,
Mm-hmm.
and I went to the hospital, and my urologist showed up. He blasted my bladder. I was in there for a week. I came out of the hospital wearing and it was all right.
Mm-hmm.
And but then I decided, oh, we're gonna have to do an oncologist. So I told Dr. Argon.
Mm-hmm.
I also wanted to keep my bladder,
Mm-hmm.
and I told my urologist that doing a bag or anything else was not going to happen at my age. And at that time I was 82 years old, and in good shape. Never been sick in my life.
Mm-hmm.
And I found a great radiology doctor,
Mm-hmm.
Chapman. I met with him. My daughter and I met with him. He said to me that I think I can take care of you. I said, Dr. Chapman, you've got me. I just don't want to be sick and I don't want any pain. Well, needless to say, he got me and he fixed my bladder. Thank God.
Yes.
So I had to chemo for 6 weeks, every once a week, radiation, 30 days, every day. And I want to tell you, it all worked. But I can understand why people don't want radiation, because the after effects of radiation last forever. And I had severe dehydration. I had severe diarrhea. Went through all that. I had bowel movements. Bowels were all screwed up. I went to a bowel doctor. I got that fixed. But I kept knowing there's something wrong with my body because everything was hurting. And then just very recently, I went to my primary care doctor because I had vertigo. I couldn't walk. I was bent over. I was going to pass out. He looked in my ear. He said one thing, Bill, vertigo. I said, how'd that happen? Radiation. I got that fixed. Then my skin started itching. I got that fixed. And there, all these after effects lasted. Well, this November will be 1 year anniversary of completion of all this. But I feel great now. I've had a lot of CT scans, all came out negative. My urologist, he saw something in recently, and I've got to go in for a procedure on Monday. He wants to relook at my prostate, but I had urine. I had urine all the time now, more frequently than ever. But I feel great. I'm happy. I feel good. And I'm so thankful for Dr. Argon and Dr. Chapman. And that's the story of my life. I'm sticking to it.
Oh, thank you so much, Mr. Hoffman. And I know it is challenging, right? Like the radiation, because I know it's a price to pay, unfortunately. Obviously, I mean, everybody has a different journey, with all of this. You've all heard, this is a very, very different journey for everyone who gets diagnosed with bladder cancer, the different treatments, the different options, and the challenges are just simply amazing, like how all of you have kind of overcome a lot of those challenges.
One thing about my radiation doctor, he was great, and he told me as things progress, more radiation is going to go through my body. He met with me every week. Every Friday, he would meet with me personally and tell me what was going on for that week, and we'd go into another week. He did that for the whole time, and then when I had my first CT scan after completion of chemo and completion of my radiation, with first CT scan with Dr. Argon and Dr. Chapman, they were both smiling. And I was too. But the after effects, it also affected my daughter, who was my caretaker at that time. If it wouldn't have been for her, I don't know what I would have done. But she drove me around. I couldn't drive the car. I was not feeling well. I wasn't in any pain. I just was not myself. And but I've grown out of that now. I eat healthy. I eat 3 meals a day. I don't drink or smoke anymore. That's been a couple of years worth of that. And being a retired Marine, you know how Marines are.
Yeah.
Sure, a lot of you do know. And 40 years in corporate America. And I'm happy with my life now. I'll be 84 years old next month.
I know.
I'm thankful I still have my bladder, and I'm thankful for everything that everybody, Dr. Argon and my Dr. Chapman have done for me and for this last year. Thank you very much.
Yeah. Thank you. But before, don't hang up yet, Mr. Hoffman.
I'm not.
Because I want to do a quick run through of you and all of the panelists, because kind of my one, maybe perhaps final question before we open it up to the floor for a lot of other participants who want to probably ask all of you some questions is, what would you tell someone, who's facing this treatment decision now? I guess from your perspective, Mr. Hoffman, what would you say? What are your words of wisdom, that you would share with them right now?
Words of wisdom are twofold. First of all, one thing you have to consider is your quality of life. You have to consider someone who's very close to you, in my case, my daughter, and decision making. I have to rely on my oncologist. I went with what she said to do, and I went with, especially with my radiation doctor, who said that he would take me on, and he would make sure I would be all right. And he was right. And I would say to anyone, listen to what your doctors have got to say. And of course, at 82, I've made it well known to Dr. Argon and to my urologist, the bag was not going to happen, because I was going to keep it. If I only had 3 or 4 years after that, I had a long life that was good enough for me. But I would say, listen to what your doctor's got to say, and then think it over. Talk to who's ever the closest person to you in your life, and go with it.
Good.
I did.
Good words. Yeah, Mr. Hoffman. And maybe let me turn it on for Patrick, this time, like what would you kind of tell, our audience, our participants?
Um, I don't know. I feel like, I mean, I've done a number of these, I participated in this group now for, I don't know, 6 months or something. And I feel like I'm the only one who's gone through what I've gone through. Everybody else has had either, they've been able to preserve their bladder, or they have the the bag. So I don't know. I I don't know what I'd tell. Yeah, it doesn't seem like my experience really applies to anybody else. So can you be a little more specific with the question?
No, just, what would you tell someone facing this treatment decision? Like, what would be your words of advice, if you will?
You mean in terms of what direction to go with the
Yeah,
versus
yeah,
neo
like,
bladder versus?
mhm.
Okay, I guess it depends on your age and overall health. Mr. Hoffman here is in his 80s. Of course he doesn't want to lose his bladder and go through all of that. I mean, it's a big deal. It's a big deal, to go through that. I mean, missing parts. It's not an easy thing to do. So yeah, it's great that he was able to have a surgery to conserve that. And yeah, so but if you have cancer, it's still stage 1, and they try some more conservative methods to treat it, and it works great. If not, it's not the end of the world.
Mhm.
You can lose your bladder and still have a life that's very active and fine. You're going to have to go through a lot to get to the other side of that.
Mhm.
It's going to be unpleasant, but once you do all of that, you'll find that it's not the end of the world, and that actually it's fine. I mean, I think of all the time about how nobody's lucky to get cancer, right? Especially me. I never smoked. I don't do drugs. I don't, and none of this. I was like the least likely person to get cancer, but somehow I did. But it's better to have what I had than something like, I don't know, pancreatic cancer, where, you have a 5-10% survival rate, or, like in the case of women, ovarian cancer is a silent killer, right? With the bladder cancer, your body lets you know something is wrong. And so, if it's early enough to get treatment, earlier the better.
Mhm.
If they can't treat it, then, have it taken out, and, life goes on. You can still do everything you need to do. And, every day, just happy to be here.
Okay. Thank you, Patrick. And
Sure.
last but not the least, Nancy.
Well, I basically asked myself when the treatments did not work. I basically asked myself, is losing my bladder really that big a deal? I was 62 at the time, and I decided that the one thing I didn't want is for it to progress and become invasive, and that it's really difficult to treat there. So my main goal was to stay alive, and I wanted to stay alive because I had a lot to live for. I would have missed all my grandchildren. I would have missed so much in the 11 years, but I just decided that I could make it through it. And as I said before, I knew people who had had the surgery, and they were doing very well. And I just, I decided that it was for me. And as I said, I'm not concerned about body image. The bag has worked very well. I find it very versatile. But I know most people, once they've made the decision of the diversion they want, they really adjust and are very satisfied with it. So, I mean, it's very rare to find someone who's made
And I
that
think most
decision and
people
then they
are
really
very
don't like it
satisfied.
for one reason or another. We all are pretty adaptable, I think, and I have a greater appreciation for just about everything.
Yes. All right. Well, I thank you all so much, to all, our panelists, here today, and for sharing these wonderful, amazing stories, and what I would like to do now is, I think if we may have a few more minutes, actually,
Mhm.
Stephanie, right?
Yes, we do.
to
So
open it
we
up
have
for,
15 minutes.
yeah.
And if you want to put on your video, if you have a question, you can just ask. You are welcome to unmute yourself if you would like. You don't have
Hey, can I ask
to.
a question?
Sure.
So I just want to tell Patrick, you're not the only one that were diagnosed early. So I was 49 last year when I was also same, just like you, had blood and urine. And when I went to my primary care, they said, you know, do a ultrasound, and it turned out to be a bladder cancer. And just like you, never smoked, multi-marathon runner. So I've completed over 40 marathons, very healthy, you know, lift weight every day. So I'm actually still in the early phases. So last year I was diagnosed with bladder cancer. They have done TERP twice so far. Initially, they followed up with mitomycin, and then it was low-grade cancer initially when they did the first pathology report. About 9 months later, they found again more cancer cells, so they did a second TERP. The second time it was high-grade cancer, and they followed up with induction with BCG. And then, so we did the induction, and then we also did a maintenance phase. So I'm still at the beginning of this whole process. So we don't know where it's gonna go yet. And so I'm due for another cystoscopy next month. But I guess, you know, it's, people think about, you know, how is it gonna end? Is this gonna come back with a high-grade cancer? It's still not muscle invasive. But the second time when they did the pathology, it was a high-grade cancer. So they said it's likely that's going to come back. So just like you guys, you know, I'm still very active. I run every day. I just, you know, ran the New York Marathon. So I want to continue to be active and, you know, play beach volleyball. So it's a big decision to make. You know, is this going to go away? What's the likelihood that, you know, I end up having to make a decision like you guys have done?
Ilaria, if I could say, even if they are able to eliminate it in the short term, you'll always be looking over your shoulder for the rest of your life. Is it going to come back? And you know, if you do the radical cystectomy, that's kind of the end of it. You know, as long as it doesn't escape outside the likelihood of recurrence, even if it's in the ureters or, you know, kidneys or bladder, neck or something like that, it's pretty small. So yeah, it's a difficult choice to make, right? I mean, you know, it's on one hand you want to keep the bladder, obviously, but you weigh that against, you know, high grade cancer and, you know, having to look over your shoulder. So yeah, just follow your physician's advice. And I would say also that if you want to talk one-on-one about this, you know, feel free to, I'm happy to do that. Feel free to get my contact information from Jenna or Karen, and I'd be happy to chat with you whenever you want.
Yeah, I mean, again, my first choice obviously would be a new bladder, just like you've done, because obviously I want to continue to be very active and do things that I do. But, you know, again, as you said, I don't know how those, you know, having to do a, what do you call it?
Intermittent catheterization.
Yeah, 4 times a day.
Yeah.
And do you carry like a catheter with you in your pocket when you go out?
I do. Yeah. I always keep a few on me. Yeah.
Okay.
And then, you know, at night, you know, as I mentioned, you know, you don't have continence while you're sleeping. And so you can't just fall asleep anywhere. You know, if you go to a hotel or a friend's house or something, you've got to bring equipment with you. But again, it's just a new way of doing things, and you get used to it after a while. It's a small price to pay in the long term, you know, in the big picture. You know, so yeah, yeah, it's not an easy thing to do, but you know, 5 years on, I'm cancer free, and you know, I think it was a good decision to go ahead with the radical cystectomy. But you know, your mileage may vary. If they're able to, you know, help you out with, you know, if they're able to eliminate cancer without, you know, going that radical direction, then that's great too. You know, so.
Did they remove the whole bladder, or did they remove the internal?
It's the whole thing.
The whole thing.
The radical cystectomy.
And
Yeah.
I would say, and I'm not disparaging at all a decision about a neobladder, but I don't want there to be any misunderstanding that people with who wear a urostomy bag do not have to avoid physical activities at all. I mean, I know a lot of people who snorkel, who scuba dive. I know people who ride bicycles competitively. I've known people who have continued to run distance. So that I mean, it becomes a preference for maybe some other reasons, but you don't have to be totally without that. I would not do crunches, as I think Kim was saying. You know, you're not going to do heavy weightlifting and things like that, probably, but you can still wear a bag and not and be very active if you want to be.
That's fair. I mean, my sport is hockey, and I can't imagine
Yeah,
playing hockey
I
with a bag
totally
around.
get that. But I know that other people worry about that, they think, oh, I will be like an invalid or something, like
No.
a bag makes you an invalid or something.
No, nobody's suggesting that.
Yeah,
No.
good.
Yeah, and I play beach volleyball, and I'm at the beach a lot of times. I don't know how it's gonna look. I mean,
Yeah.
I don't know.
It's more than just vanity. And by the way, it's like, I don't think anybody should feel ashamed to say, I don't want the visual, impact of this thing on my body. Yeah.
I agree.
Yeah. But I mean, you can be active, but maybe not as much as you were before with the bag. That's just in consideration. Not to get too far off the subject, the most important thing is getting over cancer. That's the number one priority. Yeah. So
if I may add to all of this with what Patrick has already said, actually not all patients with neobladders need to self-catheterize, right? I mean, there's also that gray zone, it's not an absolute must, so because there are patients with neobladders that do not. So
Can you expand on that a little bit?
yeah, I'm curious to hear about this as well, because
yeah. No, some patients, and Karen, you can also, sort of weigh in on this, because we oftentimes, so remember, and the challenge, sometimes with, of course, neobladder is, as you pointed out, Patrick, that first, few months, your body is relearning, how to do, to urinate, pee out of your new bladder, right? So I have another patient who told me it's kind of akin to urinating or peeing out of a plastic bag, where you used to have a muscle, for your bladder, and now it's a very pliant, like, and even though you're thinking I'm gonna go, it doesn't always, happen, that way. So some people may have, not the greatest control, and therefore, there's residual urine, in the bladder. Therefore, you have to self-catheterize so that we can avoid, other complications like UTIs, But for people who are able to control the sphincter, like the control of the bladder, they can, do without. Now, I'm not suggesting at this point in time, start doing that, try not to do self-catheter, because that should be only under the direct supervision of the physician. But maybe Karen, would you want to add to that?
Well, I was just going to say, just like everybody's different, not all neobladders are created the same. And they don't all act inside your body the same as the next person. And then some people have to catheterize, for a while. And then once they are able to get their muscles to, kind of work properly, then sometimes people are successful in eliminating all the urine. But it just happens that, some of the, even there are different neobladder techniques. Am I right?
I
Dr.
can,
Aragon-Ching, yeah, so that, you know, it's not all the same model, I guess is my point.
yeah, if I may, I can urinate normally, like in a normal fashion. Is just two things. Number one is that it's very difficult to void completely, and so it it fills up more quickly. So that's why I do it. The other thing is too, because the neobladder is made from small intestine, mucus can accumulate in there, and that's why they call it clean intermittent catheterization. If you don't void, that mucus is going to stay in there, so yeah, I don't know. I'm curious to hear who can actually have a neobladder without catheterizing. I don't doubt it. I'm just curious how that's possible, but yeah.
For more information, if you go to bcan.org and go under the video tab on one of the tabs at the top, we actually did a program, the care and keeping of your neobladder, the care and keeping of your ileoconduit. It really covered some of the regular sorts of things that people need to know, as well as some of the unusual things. So there's a lot of really good resources. We're coming almost up on the 2-hour mark. So I'm just going to try to wrap it up. If you all have any closing comments, I know that there will be an evaluation that you'll be getting. I hope that you will complete that, and it's very quick, and you can just put in your thoughts about the program. And then remember that next week on the 18th, we'll be dealing with treatment advances for advanced disease, and then also covering the issues of intimacy and sexuality, which cuts across all the different diagnoses, and then talking about coping strategies. So even if you don't have advanced disease, you definitely want to come back on for next week and cover those additional topics if they're of interest to you. I think that would be really helpful. And I know that thanks to the work and the dedication of people like Dr. Aragon-Ching and the folks at Inova Schar and all the other big hospitals that are doing so much. 5-6 years ago, there was not a whole lot of options for patients. And then now we have a whole lot of, we have a plan B, a plan C, a plan D, an E, an F, and an ADC, and all kinds of other things. So I think that to me is, really a symbol of where we are right now. And bladder cancer research is really kicking off. There's a lot of very smart people. Beacon does a think tank every summer and really brings together some of the smartest and brightest people in the bladder cancer space. And we support bladder cancer research. So sign up for the walk and help us out, raise awareness and raise funds for Beacon, but also know that there are really smart people working all the time on finding better solutions so that there is good quality and quantity of life. So with that, I think we're coming up on the end. Dr. Aragon-Ching, any last minute comments, or Kimberly, anything else that you want to say?
Just thank you all so much, for your dedication, and everybody here, on the panel, and as well as all of our participants. Thank you.
And thank you for Beacon for partnering with us.
Oh, it's our pleasure. And we'll see Karen and Jenna next week, along with some other folks. So remember, advanced disease, intimacy, sexuality, and coping strategies. Don't miss it, the 18th. We'll see you here in the Zoom room. Take care, everybody.
All right.
Thank you
Bye.
all.
Thank you. Bye. Thank you very
Bye.
much.